With that, I'm going to open up with a few questions for both Dr. Kim and Dr. Huber, and the first one is simply to ask, because I know this is on the minds of many of our families, is how a family actually goes about seeking a second opinion. Do clinicians, like primary clinicians, do they make suggestions or recommendations to see someone at a different institution, for example? So I think a lot of parents are a little uncertain about the process of asking for a second opinion, and so I'll ask Dr. Kim and Dr. Huber if they can address that question. Susan, do you want to go first?
Yeah, sure. Yeah. No, so I think when it comes to getting a second opinion, it just starts with wanting a second opinion or needing a second opinion from the point of view of families or the local treating clinician. And I think it really is as simple as that, the starting point of just asking for a second opinion and talking to your local rheumatologist about that want or desire. And I think that there's a lot of hesitancy about doing that because I think everyone's a little bit shy. They feel like maybe they'll hurt the local rheumatologist's feelings and things like that. But I think that that largely and in the vast majority of cases is not the case, and that as a tight-knit pediatric rheumatology community, we tend to work very well together, and just I think asking is the first step to getting a second opinion. I think one of the questions embedded in there was where you might get a second opinion. So I think that largely depends on each institution, depending on the size of the institution. For example, a small institution, it might not be a very good idea to get the opinion from the second person who's there, because it's most likely they're very, very similar and aligned. But that also might be true even if it's a large institution too. So I think it really does depend on whether what kind of clinicians make up your team at your institution. But also, you know, there's so many other resources outside of the local institution that clinicians can take advantage of. So I think talking to your local rheumatologist about who those people might be would be great. And CureJM, I know, has always been a great resource to point patients in the right direction if they need help in identifying a JM expert.
Adam.
So Jim, I would basically agree with pretty much everything Susan has said. I like to tell families when this issue comes up that they have a right to ask for a second opinion. It shouldn't be a big deal. It shouldn't be a secret. It shouldn't be an insult or any of those kinds of things, because in general, I think most clinicians are very open to the idea of having somebody else provide some extra information and to weigh in. I think one of the pieces of the question that you were asking, again, it's also kind of embedded, is the idea that how should you go about doing it? And I think it's almost always preferable to do it through your rheumatologist. And there's lots of reasons for that. Certainly one of which is that your rheumatologist has the MRIs and the blood work and the history and all that information that they can provide. And so trying to pursue a second opinion independent of your physician certainly may actually have a lot of challenges, and may be that you don't get the same sort of quality of response that you might get through your rheumatologist. When I was thinking about this topic, the one circumstance where I think this does get difficult is when the second opinion is because you really don't mesh with your rheumatologist. There's a personality conflict, there's a style conflict, something just isn't quite right. In which case, you may not be looking for a true second opinion, but you might actually be looking for a transfer to somebody else. And again, in that circumstance, I think it's probably better to put your cards on the table and be honest about your concerns, because again, the information that your physician has is going to be invaluable to anybody who's going to try to provide some sort of an opinion or some sort of a second assessment.
Mm-hmm. Susan, I know you have done a lot of interaction and consulting with clinicians elsewhere in California, in Southern California, as I recall, who you know, who perhaps don't quite have your level of expertise in JDM. Is that like a second opinion, or are you sort of being more of a consulting clinician in that kind of an example?
Yeah, it really depends. It depends on the clinical case and the comfort of the family with the care and relationship they're having and with their local clinician. And that doesn't necessarily even speak to the expertise or the competency of their local rheumatologist. I think that families often have a feeling of wanting a second opinion because of the rarity of JM and wanting to see someone who's seen more than just a handful of JM patients in their career, varying severity and so forth. Many patients that I see as second opinions come maybe every 6 months, even once a year, to check in, just to you know, get a tune up or just to make sure all the ducks are lined up in a row. And there are certainly instances where when patients only just come once and they're satisfied that treatment is pretty much aligned. And sometimes we leave it at that, that treatment is aligned, that they won't come back. But then if there's a bump along the way, I have had patients come back too. So I think it really very much depends on the clinical situation and the families and the local treating provider. But when it comes to just communicating with local rheumatologists in the care of the patients who are coming for a second opinion, I've almost never, I can't say never, maybe once in my life so far, but virtually never have a problem collaborating with other rheumatologists, giving them my point of view and my recommendations, and then, you know, telling them why. And if I explain the reasons why certain treatment recommendations are made, everything is pretty well accepted, and there's a lot of shared care and decision making done for the families and patients. So I think it really works out rather well in general.
Question for Adam is because JM is heterogeneous and the presentation of symptoms is often complex and different from patient to patient, is there some need for many, if not most, JM cases to actually seek out a second opinion?
You know, it's an interesting question. There's no doubt that the juvenile myositis is rare. There's no doubt that there are levels of complexity related to investigations, related to complications of treatment or complications of disease. At the same time, I'm not sure that it's always necessary to have a second opinion. Just like the disease varies, the expertise of clinicians varies from people like Susan, who've seen many of these patients, to other people who may only have one or two in their entire practice. And the reality is that some kids with dermatomyositis are actually doing really well. They have fairly typical disease. They've responded well to fairly typical therapy. And again, I'm not sure that it's necessary, if all is going well, to have that second opinion. At the same time, though, I think if there's any question in the mind of the family or in the mind of the physician, then a second opinion should certainly be, I think, an easy thing to move to. But I would hesitate to say that everyone with dermatomyositis needs a second opinion, particularly given limitations on resources, limitations on space and time, and the fact that really we know that many kids do really well. I certainly think that in the more complicated courses where therapy hasn't gone well, there are complications, there are concerns about the approach, then there's no question in that circumstance.
Mm-hmm. A question for actually some of you parents and Shannon and Susan maybe here in the U.S. is what are the implications for insurance coverage for second opinions? Should parents be certain to get like pre-approval or pre-authorization before they even move down that path? And do you typically not have problems with having insurance pay for second opinions?
Yeah, no, I think it's always been an issue. I don't know if it's a more prominent issue now, but it feels like it is. But certainly I always would like families to have like prior authorization from their insurance before they come for a second opinion, because those bills can be awfully big, especially at the tertiary care institutions to get second opinions, and we don't want families stuck with those kinds of bills. So yeah, I would really encourage getting insurance approval for this. And we have hit some hurdles where insurance says no, but then usually we can provide letters, and the local clinician provides a letter. Sometimes we provide a letter saying the reasons why a second opinion would be of benefit, and it's almost always worked. Especially as oftentimes second opinions, more often than not, I feel like the first time second opinions allowed. It's the follow-up ones that are maybe a little bit harder. But it seems like when appropriate letters and documentation are provided about the reasons why a second opinion would be helpful for the families and child, we've often been able to overcome that hurdle. So don't come without authorization. I don't want a big hole in everyone's pocket from a second opinion. I think it could be worked out.
Yeah, and I would just add a really helpful resource can be at your insurance company, a caseworker, or an employee who's taken an interest in kind of helping you guys navigate the system. And a second really good resource can be the second opinion institution's financial department. So there may be a different billing code that they could use. Oftentimes that second opinion institution will be willing to talk directly with your insurance, with your approval, and figure out what might be allowed and what might not be, and then communicate that to you and the second opinion doctor. So those two resources can work together and make sure that this is something that works for you, and you're not surprised by an out-of-network bill.
Adam, could you share with us a definition of refractory JM, sort of exactly what that means, and if a parent hears those words from a clinician, if a second opinion would almost automatically be considered necessary?
An interesting question. I can see Susan smiling because these are sometimes the kinds of words that we actually debate, and we get into discussions about what is actually meant by some of these terms. I suspect refractory probably falls into that category a little bit, in terms of most clinicians would know what it was when they saw it, but coming up with a specific set of words that define it well, I think is challenging. Certainly for me, a patient who's refractory is one who's basically not responding on the trajectory that I would anticipate. Probably the most obvious is that we're not weaning steroids on the trajectory that we'd like to. The CARA treatment plans are estimating that people will come off steroids at about a year. And if you find that you're still on high doses of steroid or higher doses of steroid than you'd like earlier or later in the course, that would certainly be a strong indication that things are not going well. I think at the same time, though, you may have patients who are successfully weaning the steroids, but there are other features that seem to be being left behind. Skin disease is by far the most common of those. You might even want to include things like calcinosis as sort of components of what refractory disease might look like. I think in the circumstance where disease is refractory, that certainly is a circumstance where a second opinion may be helpful. There may be approaches, there may be new medications, sometimes even medications that are sort of in the spectrum of experimental therapy that might be considered appropriate in that circumstance. And somebody who has dozens or has seen hundreds of dermatomyositis patients may be much more likely to be aware of kind of that new research than somebody who's a general rheumatologist and only has a handful of patients. So I sort of think in that circumstance where there basically are challenges in the course, a second opinion is probably actually as useful in that circumstance as in any other one.
Susan,
Susan, you want to add
anything you'd like
anything to that? Sorry.
Yeah.
Yeah, I think, I think the definition is challenging, as Adam said, what refractory disease is, but, conditions in JM where you have ongoing muscle inflammation or weakness or skin inflammation that doesn't respond to the treatment you're on, and especially if you can't go down on your steroid dose. And there are some medicines that are quite familiar to rheumatologists in the treatment of JM, like methotrexate, like Plaquenil, like steroids. But perhaps some of the second and third line agents, when it comes to refractory disease, maybe some rheumatologists are less familiar with. As Adam said, like some of the more out of the box treatments that some clinicians are using. So in those cases, especially if the comfort level is not high with the treating rheumatologist, then a second opinion for refractory disease completely makes sense, I'd say. Yeah.
Great. We have a couple of questions that have come in on the chat. Shannon, could you handle those questions for us?
I actually can't see them.
Okay. Well, here I have
Oh,
them.
there,
have
I
them here.
see. I see now. Would you like me to read it?
Yeah, that's great. It'd be the one from Martina.
So this is about a second opinion from the Philippines. So that might be a question maybe for Simonetta. How would we get a second opinion to the Philippines? And this may be one of those cases where telemedicine is something that can be useful.
Yeah, I agree with you. I'm sorry, I didn't see that chat question either. I'm not
They're looking for a second opinion
Opinion.
outside of the US or Canada. And so is that something that the GW clinic can do by Zoom? I believe they can actually.
Yes, yes. I believe so. Yes.
Yeah. And
So,
yeah, I was also going to, sorry to interrupt, mention
no,
the
go
GW
ahead.
clinic
Please.
also for second opinions that don't need insurance coverage as an option with Lisa Ryder and her team there. That would be a great option. One tiny silver lining of COVID is that telemedicine has grown and developed and become more accessible to different patients, even outside of the local institution. At the start of coronavirus, we could only really see patients that were within our institution, but now it's been augmented, so we can see patients more broadly outside of state as well. So I have done that during this period of coronavirus too. Definitely most ideal would absolutely be an in-person visit, because I think there are things that you can see on exam that you can't see through a video screen. But second best certainly is a video visit with a second opinion.
So I think the recommendation there might be you could contact Dr. Kim's office at UC San Francisco if your insurance would pay for that, and if not, Dr. Lisa Ryder at our Center of Excellence at George Washington University, and Simonetta D'Onofrio can get you in touch with Dr. Ryder's staff to, in both cases, I think, set up a telemedicine visit. Great. So at this point, Adam, I'm not sure if we covered everything on your slides or not, or if you'd like to go through those, or we could just open up for some more general questions.
I think to start with, if there are some general questions, I think that's probably much more interesting than my boring slides.
Well, your slides weren't boring, but okay. So from the floor, then we've had a few people who have. I thought I saw a couple of hands raised. So if anyone has any questions, please, please, this would be a time to come up with them.
I'd just like to say a little bit on experience with my granddaughter. She was diagnosed 8 years ago, and the rheumatologist she started with, well, my daughter didn't know, she didn't know where to go to get her daughter treated, for one thing. And the rheumatologist in the hospital that treated her really had very limited experience, if any, with the disease, and she was not responding well. So she took it upon herself to find a second opinion. And I think parents should realize that not every part of the country is a local rheumatologist going to be an expert in the area. And so they may need to really advocate for their kids and not just depend on what the local medical community can do.
Thank you, Randy. That's very true.
I think it's better now. It's better now than it was 8 years ago, but still there are vacuums in various parts of the country that just don't have the experience with the disease.
In the past 6 months or so, I've probably made a half a dozen, or maybe a few more than half a dozen referrals or introductions to pediatric rheumatologists who are known to us to have a high level of JM expertise, from families who I think were in very similar situations, Randy, where they were seeing someone who just wasn't quite certain, didn't quite have the experience that might have been called for. And the clinician themselves did not suggest, I think, a second opinion. So if any of you do have any questions about those kinds of referrals, we do know where those clinicians are in your general geographic area, and can make referrals to not medical referrals, but introductions, if you will, to clinicians or hospitals that you might find useful. So do feel free to reach out to us if that's the case.
Jim, if I can make a comment, I think sometimes it's very hard to know what you don't know. And so somebody may not be aware that this is not going the way it should be going, or this is going slower than would be anticipated. I think that's certainly a circumstance, again, where I think families should feel empowered to say, I'm a little bit uncomfortable here. How many patients with JDM have you seen? And look at being seen at a more regional center like Seattle, like Chicago, like GW, like UCSF, where there's somebody who's recognized as sort of thinking about and seeing a lot of JDM patients. Again, I think I emphasize that I really think asking for a second opinion should really be considered a right. It's not something that is to insult or to demean the person who's providing care, but really this is rare stuff. It's not the kind of stuff that everybody spent a lot of time thinking about.
Oh, and then I just wanted to say one other thing too. I wish, just in terms of treatment of kids with JM, I wish it was a one size fits all, like, just do this and you'll be fine, and come back in 3 years and you'll be off medicines. Like, I wish there was a one size fits all that could be recommended for all patients, but definitely all patients have different degrees of disease severity, and also different families have different degrees of ability to accept risks of different medications or different ways to accept medications. For example, I definitely prefer injectable methotrexate for all of my patients with juvenile myositis. And if you didn't know me, you'd say I was the meanest rheumatologist in the world. Like, why are you poking all of these children when you could take it orally? But obviously it's because it's absorbed much better and more effective if it's done by injection. But there are certainly families where they cannot tolerate that. The child cannot tolerate that, and that can't be an option for them, injectable therapy. So, even if in my mind there is a one size fits all for certain severity of disease, really, modulating treatment that can be accepted by the family and the child is really important, because you could write every prescription in the world for a patient to take and all these recommendations, but if they're not able to administer them at home when they're at home, the rest of the 365 days of the year, then obviously it's not a good recommendation. So I just wanted to throw that in, that definitely it's not one size fits all for treatment for patients with JM.
I just wanted to add another comment of a situation that came up earlier today with one of our youngsters, who I believe is 4, and the local rheumatologist actually diagnosed her with possibly having a second autoimmune condition, which we all know is very common. So she reached out for some assistance, and through a second opinion, we were able to help her connect with not only a second opinion on the JDM side, but also on the other conditions, so those doctors can work together. So another value of a second opinion can be sometimes having more than one expert that they can kind of collaborate together and help make sure that all the different medications and all the different treatment options are considered given the whole child situation, and not having 2 different doctors working separately on 2 different conditions.
Other questions from the floor on this topic, or any other question you might have for Dr. Kim or Dr. Huber?
Just echoing Sarah's comment that a second opinion put their minds at ease, that they were on the right path for Jack, and helped him feel more comfortable with everything our local doctor was doing. Yeah, no, I think that reassurance is kind of invaluable too, because these are tough treatments and you're on them for a long time. So if there's really uncertainty, and you're giving your child these medicines every day or every week, or with whatever frequency you're bringing them in for infusions, it's a hard thing to do, and feel good about it all the time if you feel unsure. So I think that the reassurance is helpful, because I know these are tough treatments to tolerate for families and for the children.
Hello.
Hello, Kumiko, do you have a question?
Well, Kimiko was my wife. I'm Ed.
Yes, I see her over on the side there.
She had her hand there.
Yes.
Our son has been going through treatments at BC Children's Hospital for the last year or so. And he's gone through most of what they recommended in the rheumatology department, going through the prednisone, the methotrexate, ABIG. All of it is giving little results, but his condition seems to be, it's not gotten any worse, but it's still not any better. So we're thinking, do we want to go outside of our local hospital? And because I think Toronto has a specialist there, JDM department actually, and we don't have that here. So I was wondering if that's something that we should maybe look into, is going to another city.
Definitely a question for Adam.
So I actually trained in Toronto, and I know the group in Vancouver very well since I grew up out there. It is true that none of the rheumatologists in Toronto or in Vancouver would consider themselves to be JDM experts, although individually they're all very strong rheumatologists. Mm-hmm. In Canada, the group in Toronto, and Brian Feldman in particular, would definitely be the strongest and most experienced people. Brian has a clinic with 100 kids at any given time in it, and has been doing it for, well, he trained me, so it's probably about 30 years now he's been doing this. So really, Brian is by far the most expert person in Canada. Unfortunately, right now travel is challenging, if not completely insane.
Yes.
Now, it's entirely possible that doing some sort of virtual discussion would be possible. I'm not sure what Brian is doing for that kind of thing. But there could certainly be a discussion about sort of what's happened to date, what treatments have been tried, what's the current status, with an assumption that at some point down the road, when we're all nicely vaccinated and travel doesn't seem like a completely dangerous thing to do anymore, there could be follow-up as far as that's concerned. But certainly in Canada, Toronto would be your place for sure. I think traveling across the border adds all sorts of issues of cost and insurance and things. So unless you happen to have millions of dollars falling out of your pockets, probably not in your best interest.
Yeah, okay, totally understand. Yeah, that's probably what we'll try and do when the situation gets a little bit better for travel. We might even look at that option. Thanks very much.
You're welcome.
Do we have any other questions?
I see a question in the chat. Yeah.
Oh, thank you, Susan.
Yeah, Veronica's asking what sorts of things we found giving second opinion, significant changes in treatment plans as a result. Yeah, and I would say that I have seen a wide range. Like I've seen definitely patients that would do exactly what I would do in terms of the way I treat my patients, which tends to be a more aggressive approach because we really want to shut down the disease process and get patients into remission as quickly as possible. I've also seen where patients maybe are getting partial treatment with medications, with underdosing of medications or not being offered injectable medications and so forth. And things like that. So making recommendations to try to get more effective forms of medication into the child. And even on like worst case scenario actually was, I've even diagnosed kids who don't have dermatomyositis, who are diagnosed with dermatomyositis too. So it's really been a big range, but the latter is much less common. But it's been like just like I would treat patients, but also places where improvements can be made. I think the biggest place where I see challenges in maybe the local community rheumatologist is maybe being satisfied with a little bit of, or what I call smoldering disease activity or ongoing disease activity, and not like kind of moving forward to try to make adjustments to therapy to really quash that ongoing inflammation and things like that. Because I think that, you know, ongoing inflammation in your muscles and your skin is ongoing disease activity that needs some kind of attention, and continuing to just go down on steroids just because it's time to go down on steroids, it isn't a good enough answer. I tend to like patients to be doing physically well and look well in terms of strength and skin examination, their labs to look well and things like that. So that's also another place where I've seen where maybe clinicians are a little hesitant to add those like second and third line agents on to really get disease under great control. Do you have anything to add, Adam?
I would agree with that, as that's certainly been my experience as well. Not infrequently, the patients that are where there's sort of second opinion advice requested are actually doing well and are on typical treatment. And the reassurance that this is the right direction sometimes is the only thing that I've really offered. There certainly have been circumstances where people have, as Susan said, used probably smaller doses of steroid, have used smaller doses of methotrexate, have used oral instead of injectable, have not added IVIG in or other sort of third and fourth line agents, when I would certainly have suggested that based on their ongoing disease activity. And I think actually one of the things that we as rheumatologists, I think, do often is the taking a step back and trying to decide, well, we thought this was dermatomyositis or lupus or arthritis or whatever illness we're looking after. it's not going the way it should, is it because they have difficult version of that disease, or do they actually not have that disease? And certainly in dermatomyositis, or in even the rarer types of muscle disease, there are kids who really, they don't have inflammatory myopathy. They have a muscular dystrophy, they have a metabolic myopathy, they have endocrine disorders. There are other diagnoses, which again, it's one of those things that if you don't think about this stuff all the time, you don't necessarily think about these sort of alternate diagnoses.
Okay, any additional questions? Well, Dr. Huber, Dr. Kim, thank you very much for imparting your wisdom, your comments, your experience. I know this has been very helpful to our families.